So welcome everyone to the Here Exposomics webinar series. I'm Yu Xiaqi. I'm a program officer at the NIEHS. It's my pleasure to introduce today's speaker, Dr. Rosalind Wright. Dr. Wright is the Horace W. Goldsmith Professor of Life Course Health Research in the departments of Pediatrics and Environmental Medicine and Public Health at the Icahn School of Medicine at Mount Sinai. Dr. Wright is a physician and internationally recognized life course epidemiologist with transdisciplinary training in perinatal environmental programming of chronic disease risk. She's also founding co-director of the Institute for Exposomic Research at Mount Sinai. Dr. Wright has a primary interest in early life predictors of developmental disorders, including asthma and lung development, sleep and neurobehavioral development. A particular focus of her research has been on the implementation of studies considering the role of social, such as psychosocial stress, trauma, other social economic risk factors, nutritional, and physical environmental factors such as air pollution, chemical allergens, in explaining health disparities among low SES ethnically mixed populations. Her group also has a growing interest in elucidating sex-specific programming effects of environmental toxins. Dr. Wright is also Dean for Translational Biomedical Science and the directing principal investigator of the Mount Sinai Health System Clinical Translational Science Award, or called CTSA. I believe you will hear this a lot in her talk. The CTSA provides support for the necessary regulatory and bioinformatics infrastructure to enable translational research across the institution. The title of Dr. Wright's talk is Enabling Environmental Health and Exposomics in Clinical Translational Science and Health Research. Please join me in welcoming Dr. Wright. If you have questions during the presentation, please post in the Q&A box and we'll address them at the end of the presentation. Dr. Wright, the podium is yours now.
Thank you very much for that introduction. Let me just get my slides here. Can everyone see?
Yes, we can see.
The slide. Okay, and please let me know if at any time you can't hear me during the presentation. So I'm delighted to be here today to speak to this group. Coming at it from another direction, not my, with my environmental health researcher and life course research hat on, but through the National Center for Advancing Translational Sciences, the NIH center that really funds infrastructure grants to facilitate clinical translational research at academic medical centers across the country. So it's really where we're diagnosing disease and caring for patients, as well as trying to think about prevention of disease. And I think we're at I kind of want to help, and hopefully we'll get some engaged discussion at the end, because this is a big area to think about. I'll talk about some of the things we're doing through this NCATS National Consortium, and let's think together what we can do at our own health systems, etc. And really what we're trying to do is scaling up, bringing environment into healthcare, the translation of research that impacts patients and improves outcomes at our academic medical centers. And there are a number of barriers to that uptake in clinical translational sciences I have found by leading our CTSA at Mount Sinai. Mount Sinai is a health system of 8 hospitals and a medical school. It's not a big university where we have a school of public health separate from what we're trying to do to engage and provide research findings to bring better outcomes to our patients. So to me, I was excited to come here about 11 years ago to really think about translation of environmental sciences, not just one chemical at a time, but really with embracing this exposomic concept. And I think that the reason this is timely to start thinking together about is because academic medical centers are now more open to incorporating environment on a large scale into what we do, because we are facing one of the biggest healthcare crises that we've ever faced, and it's really related to climate change, and everybody identifies with that. There's data to show how the warming of our planet affects extreme weather events that have both direct and indirect effects on our patients' outcomes. Enhances a number of environmental exposures that are shown here. We won't go through a lot of these, but really it does impact all aspects of what we all think about as the exposome. And that includes ambient air pollution, multiple chemical exposures. It changes the quality of our food and access to our food sources, to less healthy makeup of those, nutritional makeup. It also impacts social environments. It increases psychosocial stress in communities that are impacted by these things, both in the short and the longer term. And we all know these effects are going to impact those who are already most vulnerable. So it's going to really enhance health disparities, which is already a big focus of academic medical centers, because it's a huge cost to what the care that we provide. And it also affects urban, suburban, and rural communities differently. And the CTSA network is a national network that does cross this country and can impact a lot of those different demographics. Well, in this picture is really just to show the ideal of what we need to do. We really need to start to harness together, curate lots of different types of big data streams together. And this is something that the CTSAs have been helping academic medical centers invest in for a number of years. A lot of it's been around genomics, and to enhance what we've been thinking about is precision medicine by identifying genetic influences on these diseases. But we all know that it really is gene by environment. So we really have to start thinking, how can we start to incorporate environmental data in those data streams as well. And then the other complication is, it's not, when we think about genetics, your genes don't really change in the time frames that we're talking about, but the environment can certainly, it's dynamic and changes over time. And we as clinicians need to understand and think about how environment impacts the natural history of disease across the entire spectrum, from the onset of disease. What role and here we're just looking at a schematic of one type of exposure that can be increased with climate change, and we all think about impacting health, air pollution, ambient air pollution. How does it affect the onset of different diseases? How does it affect the severity of the disease if there's ongoing exposure or shift in your physiology because you've been exposed during a critical window? And we may be treating diseases that the biology is just different because we haven't accounted for the number of environmental influences on shifting a number of interrelated pathophysiologic systems. And so all we're doing is enhancing toxicity of those treatments, but not giving patients any benefit. And we see this across a number of diseases: cardiovascular diseases, respiratory diseases, mental health disorders, et cetera. And how does ongoing exposures aggravate therapy-related injury across as we care for our patients? So we need big data analytic in exposomics, but we also need to be able to bring in the exposure data that may be health relevant to the natural history of these diseases. Well, it's easy to get overwhelmed, and honestly, it's not hard to overwhelm clinicians who are already overwhelmed to start to think about these things. So really what you have to do is manage what are the priorities? Where can we start? Where are the strengths at our own academic health system to start to think about doing this? There may be things that are already going on that you can do to start to build those. And that's what we've tried to think about here at our health system. And I'll share some of that with you. And perhaps that'll give us ideas on how we can do things on a more integrated multi-site scale. We actually took a step back and said, what are the barriers to uptake of environmental exposure data, let alone exposomic types of data, which is where we want to get to in clinical translational sciences. And these are the 4 areas that we've tried to respond to. Accessibility. Health researchers in our academic medical centers often are very unfamiliar with where and how to access environmental exposure data. A lot of what happens in environmental health and exposure assessment, et cetera, does not happen in academic medical centers. It happens in schools of public health, which largely over the years had been divorced from health systems, and we are trying in many ways across our health, our institutions, to bring those 2 back together. Here we're a little different because we are a health system, and we have actually tried to build out capacity to do this without a formal school of public health. Interpretability. Also, they're not trained to just feel comfortable with the characteristics of exposure data, uncertainties, et cetera. We need to put expertise around them that can do that and bring that into academic medical centers. Implementation is also, how do we curate the data and actually translate it back to the healthcare providers in the end, not just our researchers, but our healthcare providers to really have impact on patient outcomes. And interoperability is really the need to integrate high dimensional data streams, which we've been, again, doing for quite some time through the CTSA. So what are the CTSAs? They're funded, as I said, through the National Center for Advancing Translational Clinical Sciences at NIH. There are anywhere from 60 to 65 institutions across this country supported through these infrastructure grants across our health systems. And they provide, as you see here, all kinds of funding to not only enhance the ability to bring together large-scale data sets, bioinformatics, clinical informatics, bioinformatics, but also workforce development. And that's another key aspect of the CTSA programs, is really you could build in the capacity to educate the workforce coming forward, who are going to have to be dealing with things like climate change, and as such, understanding environmental health in a bigger way. And they have been for a long time harnessing electronic health record data on patients and starting to think about how do we link that to create a common data model, parameters that can be used in research that we can disseminate then to our research community, but also be ready to translate that back to care for our patients. We really experienced that in a major way during COVID, when we are all focused on one disease, and we saw what the possibilities were if we really put our resources and intellectual capacity together to really build these kinds of data streams. So CTSA catalyzed major new informatic capabilities across the health systems. It's built and invested in high performance computing, computational, multimodal data science ecosystems, and we'll take a look at what that looks like. And also brings in available informatic experts, supports informatic experts needed to take advantage of that data. And then moving towards what are the types of analytic tools that we need in computational science to really take advantage of that. And there's a huge push to look at artificial intelligence. Many people here in the clinical world, like to think about more as augmented intelligence. It doesn't have the same connotations. Machine learning, and it's teaching not only the new folks coming through, the early stage investigators, but also educating our more senior staff who haven't been using these kinds of things before. That's just a picture of where we sit in Manhattan, but we're an 8-hospital system. We're on one EHR, electronic health record system, which is Epic, and we can actually pull together data on millions of patients together across the health system. If we could link that some way to environmental data, I think that we'd have huge power. And you'll see CTSAs don't just think about what can you do at your hub, how can you also make this interoperable across multiple academic medical centers and other organizations to really have open data science and really be able to do this on a large scale, because we all know it needs to be done. That's a lot of changing the culture, but also training the workforce. But also there's resources that have to go in to build the computing capacity to be able to do that. So our goals are to make as much data and computational resources available as possible, provide the integrated computational data science ecosystem for our investigators, but also, as I said, outside of our hub. And you don't have to be a part of a CTSA necessarily to take advantage of some of the resources that are stood up by the CTSAs, which is also important to understand. And then bringing the experts together and training transdisciplinary scientists. And this kind of says the same thing. This is just the structure of what we do in a simplified way. You know, this is what many academic medical centers are doing with their EHR data, their electronic health record data. Unfortunately, we're not all on the same electronic health record, although when you look at Epic, Epic is becoming the industry standard by and large. So many academic medical centers do use Epic as their EHR. It comes in, gets ingested and as identified data from the EHR, and you can bring in all kinds of data, lab data, diagnostic data. You can actually use tools to actually extract from physician notes, etc., as people identify priorities there. And then you have de-identified data sets that can be disseminated very broadly to Mount Sinai researchers to start to do some of their science. It doesn't require IRB to be able to recontact those people, but if there are options available, because we know how valuable that is to be able to get that human subjects approval, to be able to do that as well. And then it's creating a common data model so that we can actually have interoperability and open community data standards to facilitate big data analytics across our health system, but outside of our health system as well. OMOP is becoming, again, there's never just one, but that's becoming one of the industry standards across the CTSA consortiums. And this is sort of the types of data streams that we are trying to build here at Mount Sinai. All of the blue that's not circled is pretty much what we've been working for over the last number of years to bring together not only EHR, electronic health record data from our patient encounters across the health system, but also imaging data that can be used integrated with that clinical data. We're digitalizing pathology so that we can do AI on pathology slides as part of the big data analytics. And then the other thing we're doing is clinical informatics, trying to think about how can we take advantage more of wearable devices, et cetera, which we all think about in the environmental health world. They're thinking about it a little bit differently. They're not doing environmental exposure assessment with those, but we need to start thinking about incorporating that in to what we do as we provide care for our patients at these AMCs. But Exposomics, environmental data has really been lacking, and people have not been thinking about how can we incorporate environmental data. Well, one way to do it is to take advantage of biorepositories that have been stood up more specifically for genetic studies in the past, but we're trying to expand the number of types of biospecimens that get put into those databases and educating folks on what is needed to do more broad environmental assessments there, as well as to take advantage of geospatial data. And I think that's what we're a little bit further along with here at our institution. So as the institution thinks about how to adapt artificial intelligence, machine learning to take advantage of this huge data ecosystem that they have, and mostly what they've been doing is looking at the sources that are listed here, and they're already doing it. They've implemented more than 30 algorithms across our health system to use the data, create algorithms that can help them determine how to best prevent delirium in elderly hospitalized patients, how to predict who might be deteriorating in the next 24 hours that might require step-up care, who in the ICU may be at risk for self-extubation, all kinds of clinical problems that we see every day. And some of these AI algorithms do a better job than we do as clinicians with the standard way that we are looking at this. So we're already showing how the benefits may be there, but what we're missing is some of the environmental data. And we know there's broad environmental data when we think about what types of things do we want to characterize for our patients that might be driving health across the natural history of these diseases. And one way we're thinking about it is how to bring in geospatial exposure data into the health system, link that to address data that we have in our EHR databases, our research data warehouses created from the Epic EHR data, and these other data streams that you saw briefly in that ecosystem schema. Well, there aren't a lot of expertise at most academic medical centers to do this type of geospatial modeling of numerous different types of exposures that we might want to have. So when I took over the CTSA, I said, well, we do have that expertise in the Institute for Exposomics. Let's grow that expertise. Let's invest through our ability to get the NCATS funding if review committees think this is something that merits that. And they were very excited about this, and particularly because of the climate change, our need for academic medical centers to respond to climate change. So we've created this platform to add to the big data ecosystem that we're building here at Mount Sinai. And it's called the Greener platform, Geospatial Reproducible Environmental Exposure National Exposome Resource. We say national because we're building it now for our institution, our hub, our 8 hospital systems to link to our EHR data, but we are setting it up from as a hierarchy so that we will be able to do things on a national scale, be able to integrate with multiple other CTSAs, but also non-CTSA organizations that may want to take advantage of this and the associated expertise that's provided along with it. And how did we do that? We started to curate data on the platform and started with things like ambient air pollution exposures. That's a particular expertise that we have here, as well as things like green space. We've also started thinking about curating data from wearable devices on noise, light at night, all kinds of things like that, and put that into the database. And we, as I said, we do it not only regionally, but also nationally. And we can, what we'll get to is the fact that investigators can play around with the data that's available on a zip code level, for example, to take a look at what things look like in the region that they might be trying to overlay on top of their patient population or cohort data or other consortium data that they're involved with. And hey, I would love to add some of these environmental factors to it, and can we do that? Once it goes to more refined spatial level, we're going to have IRB in place for them, et cetera, and provide expertise to guide them on using those kinds of data. So we're setting that governance structure up as well as part of this. And then hopefully we'll start to build research, bigger and bigger research that can address things like climate change. We're also thinking about social determinants of health. So the other things we can do with our map is to look at redlining. We all know that certain policies that were put in place to provide investment into different communities was based on this Homeowners Loan Corporation, which created security maps back in the middle part of the last century, and what was best to hazardous, for A to D, D being the hazardous communities. Well, the hazardous communities, and to a large extent those in the categorization of C, definitely declining, but weren't allowed to have investment in their communities. That was blocked in different ways, and that was largely in historically minoritized populations of color. And if you look at it today, 74%, 3/4 of those neighborhoods and communities, and this happened to hundreds of cities across this country, 3/4 of those are rated still as low to moderate income today, and they are still primarily ethnic minority populations that are living there. So that speaks to the whole disparities angle. This just shows, overlaying on that redlining map, air pollution exposure levels to both elemental carbon and organic carbon. And what it exemplifies is what we already know, that there's just disparate distribution, particularly in those vulnerable populations that lacked resources in their communities. This is a little easier to see because as you go from grade A, B, C, D, from left to right, these are 7 air pollution levels mapped there in those communities, and you can see that air pollution levels across the board increase as you go across those types of communities. We need to understand that. We need to understand why there are hot spots when we see increased hospitalizations and ER visits for certain disorders, when we have heat waves or we have burning wildfires like we experienced here in New York City from those in the northeast of Canada blowing down to Manhattan. We're starting to see more and more of those types of extreme events happening where they didn't typically happen in the world, and we're all going to be impacted by these, but it's particularly going to hurt those communities that are already vulnerable and sitting on the edge, and that's ethnic minority populations as seen here. Well, it's also increasing exposure to social determinants like safety, crime, violence in these communities where there's lack of resources put into these communities. As we see more climate change effects on these communities, those resources are going to be becoming even more scarce, and that begets other factors that alter their emotional experiencing of those environments, like safety, etc. As air pollution levels go up in these communities, safety is typically going in the other direction. So that underscores to me that we cannot ignore those social factors, the other environmental influences that are going to be increasingly impacting our ability to care for patients, the diseases that we see, the treatments that we need to come up with, etc. So we need to put that in to our system, the entire system, and environment in the exposomics needs to be a big part of that. That's going to take huge investment. It's getting organizations like NCATS, the CTSAs, who hadn't been thinking really and still are not thinking enough, in my view, about environment and how we bring it into what we're trying to build here to be able to do it. This just shows you that it's not just Mount Sinai. This happened during COVID, where we all shared our EHR data centrally using the common data model so that we could help all of us figure out how best to care for patients with COVID. And you can see the number of institutions that gave data into that. That database is available for researchers to use, but NCATS is thinking, well, you know, we shouldn't lose momentum here. This really sort of broke through, and academic medical centers learned how to really start to share the data in important ways. And can we do it beyond COVID outcomes? That's going to be a big focus of the upcoming meetings of NCATS in the next 3 or 4 weeks, and something that we are all pushing towards. So the momentum is there, and the need to get environment into that is being recognized, but we need our experts to come in and help get that done. The other thing that NCATS is doing is creating educational materials for integrating environment and exposomics into translational science, because we do think, and this was something that we had worked on just prior to COVID. We were just finishing up some of this work, and then it got stood up during COVID. But this is available. This is a toolkit that was developed to help us across NCATS or across the CTSA network, but really for anyone to be able to utilize to help think about how to educate and train the next generation of clinical translational scientists to be able to incorporate these types of methods, understanding that there are already tools available that can be used and leveraged to be able to do this and bring this into clinical translational science more and more. These are the kinds of topics that you can choose from. People use this in some of their courses, maybe in a reverse classroom type of model where they'll have the students read or see some of these videos, these online videos, and then do more practical work around these issues when they bring them into the classroom for that. There are lots of ways you can take advantage of this, carve it up in lots of different ways depending on what you need. So that was the idea, to create that educational toolkit, really to enable inclusion of exposomics, environment, GIS-based data, wearable data input into our data streams that we're already thinking about in translational science. Because we really do need to get to this. We need to get to this open data science, open, big data to enable AI to really help us, because we're just seeing increasing greater morbidity, greater number of comorbidities in our patients, more severe disease early, lack of response to what we think should be good treatments, because we think we understand what the underlying pathobiology is. But we all know if you don't know this, put them into the context of the environmental influences that are pushing and pulling on those pathophysiologic systems, you're really probably most of the time missing the mark and just causing side effects from the treatments, but not a lot of benefit from the treatments. And that we know needs to change so that we can get closer to precision prevention, more effective treatments, and fewer side effects for our patients. So I'm going to stop there and see if there are questions that have come to mind.
Thanks, Rose, for the great talk. If you have questions for Dr. Wright, you can post in a QA. I do have a couple of questions. You kind of point out that there's kind of little environmental health research in the space of a clinical translational science. I think that's the reason we are having the talk and the discussion today. You can also, mention the barriers, all of those. I'm just wondering, since CTSA actually, it's a network, and NCATS has been funding this. So we just wonder how many CTSA sites, active awards now, and how many of them might be thinking about incorporating environmental exposures
Yeah, at any given time, there are between 60 and 64 institutions funded. Currently, I believe it's at 62 across the country. New York City, for example, has a number of them here at Mount Sinai, Columbia, Einstein, Montefiore, Cornell, and Rockefeller. And then we have other ones, Buffalo, we have Yale, we have Rutgers, and we actually, it is encouraged, it actually is very much encouraged for the CTSAs to not just focus on your hub, but to think together how you can do things bigger. So we have regional ongoing discussions on how can we do this across our regional network. So we talk to our other CTSA partners here in the northeastern area, but also even more broadly than that, there are other institutions that are thinking about this. University of North Carolina is one that's, for example, really been thinking about this, even in the context of their CTSA. There's a lot of great environmental health expertise there, so that helps. But not enough. I would say just a handful of those are thinking about it. There are mechanisms within the CTSA to do what's called optional functions, and they label that differently as things evolve across the network and how you're going to do that. But that's for a particular hub to say, hey, we have this expertise and we'd like to bring it to the network. And that's how we've done what we're talking about here, is really, we were funded to be able to do that, to start to bring it more to the network. It's starting. I think we have leverage because of the climate change issue that we're all facing. We have to deal with it. It's going to be one of the most costly things that medical centers are going to be dealing with going forward. They understand that. They know they need to get their hands around that. So I think we're right. We're right for the time to be able to do this.
That's great to hear. I think a couple of questions here. One is that, do you have any insights into the quality, accuracy, and history of things like addresses within medical records?
That is a challenge, and that is something we all know it when you get in there. It sounds like an easy thing. So we do have worked out workflows to be able to do to have a look at that and see how much confidence we have in different ones. How can we track down? How can we do better? And then there are some that we think we can't use in the end. So it is true. The other thing that has to happen in medicine is that we have to get more standardized in how we enter these things, because we now know how important these things are. An address and an address change over time in that particular patient or group of patients is going to be very powerful, given that you can link it to some of the things we've talked about today. That has not been what medical records are about. So we have to have those conversations. And then another thing the CTSAs could have impact here on is standardizing some of that. And that is something that's going on. Those are conversations that are also happening in our world in NCATS.
And I would also like to add, even for the epidemiological studies where address is purposely collected for the purpose of incorporating environmental exposure, there's still challenges about accuracy and history and those kind of things.
Right. Yep, exactly. The rigor, it's true in all of our studies. There are unique challenges, I would say, to electronic health record data in that regard.
And the next questions, are there particular disease areas that will benefit the most from the integration of exposomics?
Well, it's going to impact all disease. We always say that we need to be thinking about it across all clinical specialties and all outcomes. But where's the low-hanging fruit? What are some of the more costly ones? Again, academic health centers are really going to be driven by saying, hey, we could really help you with asthma, for example, which we know is an environmentally driven disease. And it's one of the most costly in the, if you look at healthcare utilization and expenditures for particular times in life, particularly childhood, for example. So we do that. We're focusing a lot around what those priorities are. Another one is cardiovascular outcomes. We know there's lots of data to suggest that air pollution has both acute and chronic effects on those outcomes, but you can, during events like the wildfires, and when we, like on June 8th of this year, when New York City was the most polluted city on the planet, it was dark here at 2 p.m. when the smoke rolled in, and we saw increases in cardiovascular events, respiratory events presenting to our ERs and that kind of thing. And maternal child outcomes are becoming a big focus too, and that's a very ripe area for doing this. So we're kind of coming at it that way. What are our big what are our needs in the communities that we serve? What are the biggest problems, and which ones we think there's health relevant environmental factors that are driving that, and how can we help bring some of these tools to lead to better outcomes and lower costs for our health system.
There's another question. Have you thought of any ways to get data on indoor exposures where people spend most of their time?
Yeah, well, there are some innovators who are doing, trying to develop different wearable devices or other ways to capture those data. How we, there are people doing it for specific disease areas and cohorts that are being developed out within our EHR data, and then trying to disseminate wearable devices, et cetera, and seeing if people can do those at home and give those back to us. Are there things that we can build into apps in our cell phones and other things that people are carrying around with them every day, that kind of thing. Indoor is more, I would say, here still within specific cohort studies that are trying to develop that, not something we could think about patient in our catchment area more widely. People are thinking about it though in innovative ways for sure, and I think that's where we need to get to, because we know it's so important.
And the other question is, are there challenges with multiple diagnoses for a patient and the timeline of development of these diseases with each EHR data? I'm sorry.
Yeah. Well, you're in much better shape if you really are in an area, and there are some hospital systems that are in areas where you really are the hospital system that's really capturing these patients and across their life cycles that they stay in. The challenge really is people move in and out, right? And we're very mobile. That's why that's something we haven't solved by any stretch. But if we can actually come up with ways that we can follow those folks, even when they go to another health system, for example, and capture them in these administrative databases that we can link, that would be very powerful. That's a huge challenge. And then multiple diagnoses, et cetera. Sure, that's true, but you can pull out as many as you think you can rigorously from the electronic health record, given the data that's there. Some are better, some are easier to do than others, that's for sure.
Another question is, as a public health scientist, my most common challenge is capturing the cumulative impacts of environmental factors in impacted communities, and in a timely manner that can inform community decisions to reduce such exposures and prevent health, adverse health outcomes. What methods do you recommend, and what is a good time frame to inform decisions?
Well, some of this where if you're mapping folks in the communities and you link it to some of these different types of exposure data or social determinants data or these different layers of data, we're doing this in our communities here. This is another thing we're doing through our CTSA and community engagement, is actually empowering the community to be able to utilize these maps to just, hey, I'm interested to see what our neighborhood looks like for the distribution of these different things. And that's kind of the things that we're doing with some of our community engagement. And that's powerful to people to see that. Now, your question of, can we do something that is more in real time that can predict what's coming? Perhaps we know there's a storm coming. We know there's smoke coming down from the wildfires, et cetera. We start to see a change. Can we do that in real time? That's the idea behind creating some of this infrastructure, is to be able to get to that. I think that's important. If we could give that information back to communities and do it in a way that people can, and we give them ways to protect themselves from what's coming, to minimize the health effects of what's coming. I think that's going to be very powerful. It takes a lot of resources to build this, to be able to do that, but we all have to start working together, and some of the things that NIEHS is thinking and doing around climate change and building infrastructure to be able to do this kind of thing will be helpful there too. But if we bridge that with what's going on in the academic medical centers where we're caring for patients, I think that's a good thing to think about.
I think we're kind of going beyond the clinical. It's more general to the entire kind of environmental health research, how you engage with the community.
Yeah.
There are two questions.
We need to bring public health back into medical centers. we can't be siloed anymore. Communities, it can't just be one-on-one doctors encounters with patients.
Yeah, there's another question actually is along the line, how to promote exposomics in clinical education training.
Yeah, well, I'll tell you, the medical students here and the house officers, once you start disseminating this information, and this is new information to many of them, although I'll have to say it's really encouraging that I do see a lot of folks coming into medical school that had environmental health backgrounds. They're getting degrees as undergrads in environmental health, and they're very interested in health disparities or whatever hook sort of brings them to us. So we try to disseminate it through some of our coursework. We're increasing knowledge base around that. I think that's one way to do it. Lots of people are learning genomic science. That's been very strong here at Mount Sinai, and many of them are now asking, how can we also think about omics approaches to some of the environmental factors that you're talking about, and they do want to learn that. And we're very much shifting our training program from interdisciplinary to transdisciplinary, trying to train. When they come to us, we say, great, you got great background and understanding in genomics. How would you like to also build some skills around environment and exposomics in that context, and get transdisciplinary training where you can really bring those things together? That's just an example, but there are many others that we can think about. It's really team science. I think that's where science is going. If we're really going to tackle some of these big problems, we can't all do it alone, sitting with our research group and our R01. It really is going to need to be scaled up.
It's encouraging and exciting to hear that on the clinical side that they are thinking about outreach into, you discuss the barriers. They don't currently have the knowledge, and that's part of the reason, they don't have access to environmental data, those kind of things. And it's also great to hear that NCAS actually, was interested in the idea of kind of incorporating environmental exposures. I'm just wondering, for the environmental health researchers, thinking about how can we help overcome some of the barriers or are there opportunities from those that they can leverage from those kind of the CTSA network, they can leverage to get incorporated into those kind of research funding?
Yeah, and I think the flip side of training our clinical translational scientists to think about environment and understand how we measure that, how do we incorporate it into our science. It's bringing in epidemiologists, environmental health scientists to understand, how do I leverage EHR data, right? How can I, that's great. Don't know a lot about how to mine the EHR, this kind of thing, do the AI. Maybe I need to learn AI methods, that kind of thing. We need to start building that capacity on the environmental health side as well, and give access to these types of data streams for you all to use. We do that. We've had a number of environmental health scientists with K awards learning how to mine the EHR data here, for example.
And it seems we're running out of questions. I think we touched upon most of those. I want to thank you again for the wonderful presentation, and it's very educational. I think we receive comments as that's a kind of teaching meeting. So it's very informative. Thank you so much. I have one more question about the, you mentioned a kind of a couple of platforms. I think it's called the Greener, Mount Sinai Greener. I was just wondering whether this platform, you kind of mentioned that it's also open to researchers that outside of the network.
It will be open to, we're developing it now first to provide a governance structure where our investigators can actually leverage it, sort of kick the tires, see how that works. For us, it's a 5-year grant for the CTSAs, and by the end, we're moving towards that. People can reach out to us through the Institute for Exposomics if they're interested in that kind of data, and we can help think about how to do that now. We'd love to help people be able to incorporate some of this data or these types of exposure data into the research that they're already doing. And we have worked with folks outside of Mount Sinai already to do that, leveraging the infrastructure that we're building. But where it's going to be more widely available, that's going to take a couple more years to really develop that on a large scale. We're just starting to populate the different environmental factors, but these are the kinds of ways we need to think about doing and do that more widely, I think.
Yeah, just wanted to bring that to people's attention. If you're interested, just be a little bit patient and wait for a couple of more years for those.
But you can reach out in the meantime to the Institute for Exposomics here at Mount Sinai, and if you have ideas on using some of the geospatial data in particular.
Yeah, exactly. Well, I think we can give back a few more minutes to all the participants, and just remind you that our next webinar will be on November 9th, and you can see the title and the speakers here. And thanks again, Dr. Wright. That's a wonderful talk and great discussion.
Thanks great discussion. I appreciate it.
Bye, everyone.